Okay, good afternoon. On behalf of Jeanette Voet, I welcome you to this session on community-based programs. It will come as no surprise that in this meeting there's a session on community-based programs. And I think they don't need much further introduction. We have been talking today about fundamental issues. We have been talking about economics, about political issues, and now we come to the heart of the matter, the community-based programs. And in the first place, Boyd Swinburn will make sure that we understand that we didn't invent community-based programs. They exist for some time, and they for long enough to have kind of a history. And Boyd will tell us about it. Boyd Swinburn is at Deakin University in Australia. He's chair of the IASO Obesity Task Force. He's member of the Scientific Advisory Board of EEN and EIN, and he's heavily involved in 2 of the Australian programs that are part of the network, and so he knows all about it. Boyd, please.
Okay, that's me, and that's my slides. Okay, thanks very much indeed, Jan. I'm going to just try to put the picture of how obesity prevention, the types of interventions have changed over time and where we should be aiming towards. They have certainly been increasing in complexity and scale quite rapidly over the last 10 or 15 years, and the evaluation designs have had to try to keep up with that in parallel. So the theory, the designs, the measurements, the interpretation has been a challenge. I think they've broadly fit into what I've called three generations of interventions. One's the package testing, second is community capacity building, and the third is integrated systems. So I'm just going to go quite quickly through those. In 2005, the Cochrane Review of the Evidence came up with 22 studies on childhood obesity prevention, and the conclusions, rather disheartening for everybody working in the field at the time, was that there is not enough evidence to show that interventions improve BMI. That review has recently been updated and was published at the end of last year. Again, you can see the explosion of studies, 33 studies in those last few years. And now they're able to conclude that significant overall effects on reducing childhood obesity. However, most of these were what I'm calling Generation 1 interventions, and mostly were less than 1 year. For those of you familiar with the meta-analysis, this is the meta-analysis for the primary school children. Anything to the left of that line for individual studies means a significant effect, and this little diamond down on the bottom here shows you the net result. It's clearly to the left side of that line showing that's overall significant. That's primary school kids. Oh God, my slides have gone through a bit of a change too. Oh well, okay. Been jumbled up. There are slides also somewhere, we might come across them, for preschoolers and adolescents. And they also, they're not as many studies, but they do show similar trends. Okay, that most of those slides have been most of those interventions have been what I call Generation 1. I'm not even sure that that slide might have dropped off. Okay, there's a system in here that eats slides. Most of these studies, Generation 1 package testing. So what I mean by package testing is that academics like us sit in universities, we work out what the best intervention is, we put it into a package or a program, we go and consult with the community, we go and do a trial, usually a randomized controlled trial or a cluster trial, and we ensure that that package is delivered with fidelity, and we test the impact of that package. And those types of studies are very valuable because of high internal validity, which means that you can be sure about the conclusions of that study, of the findings for that particular group. but their external validity, how relevant they are for worldwide real experience, is more limited. Generation 2 studies take a more complex view of it. The question is now not, does this package work? It's a more nuanced question saying what works for whom, why, and what context, and at what cost. So increase in complexity of the question, an increase in complexity of delivering these programs, and they are now engaged with the community, in partnership with the community, implemented by the practice and local experts, not implemented by any people from the university. It does suit sometimes a randomised controlled trial, more often a quasi-experimental trial, and now we're getting some payoff between greater external validity, so in other words, much more close to worldwide, real-world application, but that creates some risks of internal validity. So examples of that are the studies that we've been doing in Victoria in the last few years. The question then becomes, what is the intervention? If it's not a package, what are you actually delivering? What is the intervention? The way that we conceptualized it is that the intervention is building community capacity. And these are the components of community capacity as we identified them: leadership and commitment, funding and resources, organisational relationships and structures, and knowledge and skills. So that's what we were trying to increase within the community. It does mean that this can be it's guided by evidence, but it's much more specified by people on the ground. So now we're paying attention not to the fidelity of the program as delivered, but fidelity to the process for supporting the community to find its own solutions. This is the 3 studies that we ran, and hello, they're all falling out of their boxes. 3 studies that we delivered worked with the communities in the Barwon Southwest region: Romp and Chomp, which was for under 5s, Be Active, Eat Well, which was for primary school children, It's Your Move for adolescents. All of these were in large communities, from anything from 2,000 to 12,000 kids. And they all had comparison groups, and they were all interventions for 3 years. And they all had significant effects. I'm not going to go through the details of those, but in these populations, they all had significant effects. So this Generation 2 type of approach has given us good confidence that these types of interventions can work. However, this is the world of obesity. It's complex, it's multi-connected, there's lots of feedback loops. This is the Foresight obesity map. And the communities, which, this is the individual in here, this is individual behaviours. These communities around them, this is the food system here, this is culture, this is the physical environment. They extend actually much further beyond the communities, and we need to pay attention to the wider group. So now people are talking about a systems-based approach. So this is what I'm calling Generation 3, integrated systems approach, and there's a lot of discussion about what the heck that means. It's now lifted up a level of complexity, and importantly, it is interventions which work within but also work upon existing systems. So you start with the existing systems, the school system, the primary care system, and within each of those they have their own systems of workforce development, of financial resource allocation and so on. To be able to take the programs and the interventions that we want, fit them into what is already there, not create something new and plonk it into the community. That's working within the system, but sometimes these systems actually don't fit particularly well. Maybe they need to be strengthened and made more robust, so that's working on the system. And now we're not asking the question, does this work? We're asking, it's an implementation question, it's a how question. How can we best implement this, and how can existing systems be strengthened to prevent obesity? So we need more, this is another level of complexity, and therefore we need more complex methods to assess it and to evaluate it. Generally, this type of approach does not fit very well into the usual evaluation tools that we have at our disposal. Often what I call the null hypothesis testing methods that we're used to around trials and randomised trials and comparative trials and so on are less suitable. You can still include them, but we need other tools, things like network analyses and systems modelling, continuous quality improvement, which the business sector uses all the time, and that's the area that the evaluation people are now working through. Taking a systems approach means you need to pay attention to the systems building blocks, and actually they are pretty much the same as what we've been talking about and doing within communities as community capacity building blocks. So we're not talking about things that are fundamentally different in terms of the building blocks, but we are now paying attention to the feedback loops and the implementation processes and how to make this scalable, how to get this across large populations, not just a single community. How do you get this across a whole city, a whole state, a whole country? So I think the closest model to that is the Victorian Prevention Community Model. I think a lot of the aspects of the EPOD system are right here within the systems-based approach, but I think it could be strengthened to make it much more a true systems-based approach. So for people like me that can't fit all of that kind of stuff in my head and say, how am I going to evaluate that? I think of it in a rather simplistic way. And I think about it in terms of, first of all, the things that have been occupying our mind for some time, which is right down here, where we deal with the public, the kids or whatever. And we have been focused in the last 10 to 15 years or so, what are the policies, what are the programs, what are the services that we can deliver to this population, and do they work? That's important, we still need to do that. And that tells us about these specific actions on the people and some of their specific food and physical activity environments. But then we've got this back of the house stuff. This is the stuff that we pay less attention to unless you focus people on it. These 5 building blocks of community capacity, and they're the same building blocks as they are for systems. So this is the system and capacity building blocks. Now, as we have seen in Australia, these will all function much better if we have high-level policies, a high-level policy driver, as is happening at the moment with a national political commitment to tackle overweight and obesity. It mobilises the funding, and that allows all of this to happen, and you've heard from Shelley Bowen how that's happening in Australia. Finally, the toughest part of all of this, that's all very well to hold in our head, but the toughest part is the system dynamics. And you've got a whole bunch of arrows there, and you have to fit them within each of those building blocks and between them, and work out which are the ones that are enhancing your intervention and which ones are attenuating it. So that's the challenge in those little box of arrows and how they apply. I haven't put them all around there because it turns it into a mess. So that's the space that we should be thinking, and I think that EPOD is well on its way to being there, but attention to systems, arrows, feedbacks and things will help us get there further. Thanks very much.